And I always laugh when Joint Commission surveyors say they go into a hospital and they say, who owns infection prevention? And the answer is unanimously the infection preventionist. And that's the wrong answer, right? Because that's what people think, right? The infection preventionist is a facilitator of that process, a consultant to it. But it's like if the nurse at the bedside is not washing their hands, then everything falls apart.
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
This week on Transmission Control, we speak with Dr. Hudson Garret, Adjunct Assistant Professor of Medicine, Division of Infectious Diseases at the University of Louisville School of Medicine. And so, Larry, today we're going to be talking about an area of expertise for Dr. Garret, which is resiliency practitioners. We'll talk a little bit about the certification, but really this whole conversation is going to be in the context of the state of healthcare right now, not only for infection preventionists out there in the industry, but really for every worker in healthcare and the stress that we've been under. And it really does require an enormous amount of resiliency to get through not only what's already happened, but as we recover from the impacts, or the initial impacts, I should say, of the pandemic.
Yes, and it's going to be important for us to focus on some of the key root causes that has resulted in such burnout, because we really can't fix the problem unless we acknowledge what those problems are. So we'll get into some of that, hopefully much of it, and we'll talk about how we then can be better prepared for the second or third or fourth pandemics that hopefully we won't encounter for centuries, but who knows, it could be sooner than that. So this is going to be a really, really important conversation that our listeners will really enjoy.
All right. Well, we're going to be right back with an inspiring conversation with Dr. Hudson Garret, Adjunct Assistant Professor of Medicine, Division of Infectious Diseases at the University of Louisville School of Medicine. I'm Justin Poulin.
And I'm Dr. Lawrence Muscarella.
From 17 Studios, let's get into it. This is Transmission Control.
Joining us now is Dr. Hudson Garret, Adjunct Assistant Professor of Medicine, Division of Infectious Diseases, University of Louisville School of Medicine. And Dr. Garret, really happy to have you on the show, and for a lot of different reasons, but I want to give you an enormous amount of, I guess, kudos for your involvement on social media. You're constantly sharing important resources. You're active in the discussion. And I can just tell you, not only as far as transmission control is concerned, but all the various podcast brands that I support, I can tell you, like, that is just something that I think has been missing in the industry, and having more voices like yours really driving the conversation is going to be so critical moving forward. So I also wanted to give you a pat on the back and a show of appreciation for your efforts there.
No problem.
Why don't you start by just telling us a little bit about yourself and the work that you do, and then we'll get into the topic for today, which I think is a unique one, and it's really around building resiliency in the healthcare workforce today. So just tell us a little bit about your background.
Sure. So my name's Hudson Garret. I'm an Adjunct Assistant Professor of Medicine in the Division of Infectious Diseases at the University of Louisville. Primarily, my focus has been on infection prevention and control and infectious diseases, but also really focused on a couple other areas like the patient's experience and patient safety, healthcare quality, with the understanding that none of the problems that we're talking about today, whether it's with a healthcare worker, a team, or frankly, a medical device problem, can be solved in a vacuum. And so I've really tried to build my career around those complex problems and trying to break down those barriers that might exist between them.
You know, I'll tell you, this idea of resiliency in the healthcare workforce, I remember when I was working as a nurse, I remember experiencing burnout even early in my career. And that was long before a pandemic or the fact that, nursing was experiencing a shortage. I would say at that time in the mid 2000s, late 2000s, that there was still plenty of nurses in the industry. But since I was in nursing school, everyone informed us that there was going to be this shortage that was coming because of such an influx of RNs to the industry and the profession back in the 70s. Now we find ourselves, in the midst of that. And then there's people like me who are no longer involved in direct patient care and utilizing their nursing degree that way. But I remember experiencing some burnout even back then. So I know the stressors of the past 2 years plus has accentuated that as well. Can you talk to us and define, that's my personal experience. Can you define, what a resiliency practitioner is and how they might address some of these concerns in the workforce today?
Yeah, I think it's a pretty complex topic, right? Number one is that we're now in sort of the second pandemic, which is healthcare staffing, to your point. And I think, when you look at nurses in particular that are extremely seasoned and experienced, what they went through before is totally different than what we've gone through over the last 2.5 years in terms of that sort of sustained burden on us, that cortisol response, that chronic fatigue, certainly the ability to make more mistakes. And so resiliency is really the ability to bounce back, the ability to handle some of those stressors at a more, I would call it almost like a sustained level, but also recognizing what's happening around us and trying to regroup. And so these resilience practitioners have been used in other industries for years. And it's individuals that usually come from that industry. So it's somebody in healthcare that understands those unique stressors, but has advanced level training on how to teach teams to be more effective, how to teach that frontline healthcare provider how to be able to still function, right, within a very, very difficult time period. And most of us have never been through a pandemic or any significant outbreak. And so the sort of lifelong impacts of this, we haven't even understood yet. And so when healthcare facilities, whether it's a hospital or an ASC or an outpatient clinic, have resiliency in sort of the center of their culture, those are individuals that normally come to work happier. They're normally more productive. They're better supported by senior leadership. And hopefully we'll start to see data that supports that they'll have better patient outcomes as well.
So Hudson, can you explain a little bit for the audience and for me as well, what might be some important elements of this resiliency program that you're saying or suggesting that the data will indicate better patient outcomes? What are the elements that hospitals would be putting in place or ASCs in order to, from a standpoint of being prepared for the next pandemic?
Well, I think number one, to your point, is the acceptedness that there will be another one, right? There will be something else that will come in the future. And so we have to say that we need to be ready for the next one. This is not a one-time event. Number two, and probably the most important, is executive level support. And when I say that, it's not writing a memo, it's not sending an email, it is true executive stewardship at the top of, the sort of top levels of that organization that say, we are going to do whatever it takes to take care of our staff. Right? Whether that's giving people time off if needed, giving folks employee counseling if needed, if they have sort of a rough shift or something like that, but also really mirroring our HR policy so that they support the workforce. I think to Justin's point, when we look at specialized nurses and specialized technicians, whether that's a reprocessing person or certainly if we've got somebody who's a specialized cardiac nurse as an example, if we don't invest in them, both personally and professionally, we're not going to be able to maintain them. We've seen this with respiratory therapists during the pandemic as well. And so you've got to have sort of the fourth element of this is really role-specific investment in these professions so that we can reinvigorate them and let them know that we're supporting them both from the top, vertically in the organization, as well as horizontally.
So how do you deal with this, or how might you recommend some of the conflicts that could arise between when you're talking about the executive level support of the workforce? What happens if the workforce, their opinions, their views, let's say with regard to vaccines, for example, what if those are in conflict? The workforce's views are in conflict with management's. How do we resolve some of those issues so that the shortage that we're facing now doesn't happen in that next pandemic?
That's a tough one, specifically in terms of the vaccine. Certainly, we have federal mandates in healthcare which, people may or may not agree with. We see many people that don't agree with these, even those that might actually be vaccinated. And so there's sort of the regulatory piece of that, which is much more difficult to change in my experience.
Right.
At the more institutional level, you've got to decide, what are you willing to accept and what are you not willing to accept? And I'll just give you an example. So let's take a frontline healthcare provider, whether that's a tech, a nurse, a CNA, doesn't matter. And let's just say that hypothetically that individual has had COVID. And let's say they had a pretty good case of COVID and they were not vaccinated and they've now recovered. Would I rather have that individual come back to work if they're wearing a mask versus put them out of work if they're not willing to become vaccinated during a shortage? And I think that's one question, but how is that congruent or incongruent with some of the CDC recommendations during staffing crises where we talk about bringing someone who is mildly symptomatic back that is vaccinated to take care of patients? And I think that's where, to your point, people start to get a little questioning, what really are we trying to accomplish here? So, like I said, there's a regulatory piece which we can't get around necessarily, but that's frankly why a lot of people have left those more regulated environments to go to places where these mandates don't exist.
So Hudson, you're bringing up a really good point, and it goes to the issue of staff members trusting that which they are told from above. So if management says they're behind the workforce, but they aren't really in practice, then that can cause a lack of trust. And I think the trust is really crucial to this issue about what we do in terms of vaccines and then how we address the shortage. Would you like to add anything in terms of that trust between the workers and the management?
You couldn't have said it better. I mean, it is such a fragile thing. And I just got back from the ARN conference and I asked groups that were in my presentation, both formally and informally, I said, do you trust your management? And sort of the, on the spot survey was about 80% did not trust their management. And that is an alarming number, especially for healthcare executives that might be listening to this. That means that the frontline staff have a disconnect in trust. And you can't have a resilient workforce if you don't have basic trust in the frontline supervisors, the managers, the directors, the VPs, all the way up to the executive suite of a healthcare institution. And so there is mistrust not only inside our organizations, but also with public health. There's been data errors, and this has been most recently highlighted this week with the CDC making pediatric mortality errors in their calculations. And so that is, I think, to your point, Larry, such an important element that if you can't rebuild that and you can't do it in your own institution, it's going to be enormously hard to do that across a broader profession. And we've got to start small and get big really quick in order for us to retain some of these immensely talented healthcare professionals that we're at risk for losing.
Employee retention is so critical right now, and it's becoming more and more important. Culture is a big part of it. One of the things that's been going on in healthcare is outsourcing to experts, right? And so over the last 10 years, outsourcing for services in healthcare has gone up substantially. And what I find so interesting is we outsource for things that are more directly, deliverable to patient care. Sometimes there's some consulting, but I feel like, and I know this comes back to being a resiliency practitioner, and you can even talk a little bit about the certification, but I feel like there's still a big reluctance to utilize coaches in the industry to be able to manage that culture. And I feel like it just the return on investment is huge, because if you can retain those employees and you can create that culture and that fulfillment, and, I can go so far as to continue that conversation into career ladder and career pathing, which is not always there or very clear to people that are coming in at entry level jobs. But, when we see this outsourcing, why do you think there's sometimes some hesitancy to utilize a coaching model to help with those issues? Because everybody knows managers, supervisors, directors, VPs, they have enough on their plates right now.
I think number one is, do we have people in management and leadership that actually have a coaching mindset, right? If you have somebody internal, maybe it's a director of a med-surg unit as an example, that is by nature a great coach, then the staff will be much more receptive to coaching in the first place. The second you start to bring somebody in from the outside that staff member doesn't know, that team doesn't know, that's an external consultant, there's probably going to be some inherent mistrust, because how do I know what that person's going to do with the data that I provide them?
Right.
Maybe it's personal data, right? It's almost like when you get the 360 survey, right? We've all gotten them, and it says this is your, sort of anonymous link, but it's your unique link. Well, if it's my unique link, then I don't think it's anonymous.
Right.
Whether it is or not is beside the point.
Perception is reality.
Exactly. So if I'm unable to trust my internal coach, then it's going to be almost impossible for them to trust the external coach. And there are, good organizations like the Institute for Healthcare Improvement has a coaching methodology program. They have coaching certifications. But if we're not willing to do that for our own staff as, immediate supervisors, it's really hard to justify bringing in external folks that are going to make sort of these third-party recommendations that don't fully understand the culture. They don't understand the system. Yeah, they may have a clinical background, but that alone doesn't make them qualified to do the work.
So what helps you qualify them? Does the certification become a big piece of that, or is that just one small component of many that matter?
Well, I think certification always helps, right? Whether that's with somebody who's in reprocessing or as a nurse. Certification is that cognitive level of knowledge that says this person met a certain criteria, right? So that's always the starting point. But let's put it to you this way. Would you want a coach that only had experience in long-term care to come in and coach a surgical staff? I don't think so. Would you want somebody operating on your brain that was not a neurosurgeon? I don't think so. So, while those are widely sort of vast examples, you need somebody that has a core set of understanding professionally of your specific environment. Now, if I had somebody who is at a sister facility, like a long-term care facility or at another hospital that was part of our system, that makes it a little bit easier because they probably really have a better grasp of our culture, sort of what our objectives are as a corporation, because healthcare is still a business. But the business of medicine is based on people. And that's really the core element of resilience, is that we have to get back to people management in order to get back to better patient management. And I hope through COVID-19, we've learned that lesson, because I certainly do everything in my power to make people feel like they're appreciated and valued and seen. I had somebody at a conference this weekend say, "You're the first person that actually saw me in the last 6 months." And that broke my heart, because she said, my manager's not even acknowledged what I'm going through as a bedside supervisor. And I thought, shame on us, right? Shame on us as a healthcare institution for not taking the time to realize that our people are at the core essence of our patients and the care that they provide.
So Hudson, I'd like to circle back again to this issue of trust. A couple aspects of my question. Do you think after COVID-19, going through this pandemic, do you think that the healthcare worker, the nurse practitioner, the physician, central supply personnel, do you think that they have less trust now in the CDC, Centers for Disease Control and Prevention, for example, who would be kind of outside counsel or kind of this external advisors that, of course, we all need to trust? Do you get the sense that, and I think you intimated it earlier, but I don't want to put words in your mouth, is there less trust in public health now and the CDC than there was before the pandemic?
I think 100% yes. There will be some that will say no. I choose not to live my life in a bubble. You have to expose yourself to multiple different things and look at different data sources. And I don't think it's a sole responsibility of CDC. I've seen the same with my own state health department. Many of us have experienced the same thing. And while no entity is perfect, I have enormous respect. Many of my friends work at the CDC. I live right down the street from it. And I have enormous respect for the work that the majority of those clinicians and scientists and researchers do. That being said, there's been some massive errors, both in communication outwardly as far as how we want to communicate guidance, the data itself, how to, understand the data. And a perfect example is, what's the true breakthrough rate for the COVID-19 vaccine? I don't really know, because we're only tracking breakthrough infections that are hospitalized or died. And even out of those, a small percentage of those are not at all related to COVID. And so I need to have sort of the total data transparency. And we do have antiquated data systems, which is a whole nother issue. But yeah, I think frontline clinicians are asking, who should I trust? Should I trust my professional association? Should I trust public health or the media? And I think, all three of those can be pretty dangerous.
So how do we rebuild that trust then? You were talking earlier, sort of to use a military model, you want to feel that your managers are kind of in the foxhole with you and you're watching their back and they're watching your back. So how do we rebuild that trust in public health? Because I have been concerned in what I have seen a dramatic adverse effect of, what has happened with the pandemic, where it seemed to me it was an opportunity to build trust, we did lose trust. How do we rebuild that trust? Almost as if the system's been dismantled, how do we rebuild it so that when a federal agency comes in and gives us advice, we know that it's because it's in our best interest rather than maybe for some other reason?
First and foremost, the federal agencies don't deliver care, with the exception really of the VA, right? We know that the VA and the NIH hospital obviously delivers some care, but it's very limited. There aren't other federal agencies that are delivering care. And so for us to sort of look at lessons learned, I think is the first step. Where is the federal agency and the federal administration at lessons learned? Where's the debrief? Where's sort of the dismantling, as you mentioned, of what we've done so far, what's worked, what's not worked? There's been some things that have worked great. Getting a vaccine produced quickly, we did that. Getting a vaccine distributed, we did that. Testing, we had some gaps. We need to look at every single element of that and then publish those failures that can be opportunities for improvement, and then also highlight the things that work so that we can figure out what to do in the future. That's the conversation I think the public wants to see. And then also reinvestment in publishing data that is truly meaningful, right? There's data for the public, which the public needs to be able to interpret. Certainly the media is out there, but then there's really more healthcare specific data, like what is true healthcare capacity? This is something I mentioned in my talk this past weekend. If your facility is licensed for 850 beds, but you're only operating at 650 because you can't staff the other 200, right? That's a difference in capacity that's not being talked about at the federal level.
It's right. It's like when you go into a restaurant now, you see all these empty seats, and yet they tell you have an hour and a half wait for dinner. And you say, well, why? And they don't really explain to you, but it's because they don't have the staff to wait on those other tables, which can be frustrating. So, Dr. Garret, again, we've been talking about the issues of trust and kind of being in the foxhole with one another. And I'm wondering if you'd like to talk a little bit about published guidelines, for example, and the trust that the members contributing to a guideline have in the organization that's kind of managing the writing of the guidelines. And there's been recently, as you know, a guideline that was revised and released within the last month on the processing of flexible endoscopes, something you and I know a lot about, the ST91 guideline. Would you like to talk a little bit about that guideline in terms of the trust that the user on the front line, the central supply personnel, the endoscope reprocessing tech, and the physicians, the trust that they would have in the guidelines content and the whole process of writing the guideline? Do you have some thoughts on that for us?
I think that differs on who you ask, right? As a patient, right? And we're all patients at the end of the day. Our expectation is those devices, those flexible scopes are as clean as possible. And really, I think if we surveyed the patients, they would think that the device is sterile. So the guideline obviously needs to be rooted in evidence-based practice, practicality, and also have the ability to be implemented successfully. When I read the sort of overall response from the different societies, I have to say I wasn't terribly surprised. This was very similar to what we saw when the FDA put out not one, not two, but 3 safety alerts related to different flexible endoscopes. And yet there was a pushback from different groups saying that we're unable to achieve this right now. And I have to ask, sometimes I hear, well, we don't have a problem. We don't have any issues here. And I always go back to the absence of data is not the absence of problems. So if you're not looking for the problem, it doesn't mean it doesn't exist.
Right.
And, Amy has a very good reputation, I think, at least in my perspective, of being very evidence-based. I think there is some discussion to be had about industry involvement in those standards. And I think that's one of the pushbacks I hear routinely. But to push back and say we can't do it because it's not convenient, which could be one interpretation of those responses, I think has a detrimental patient safety impact, one that we should very well sort of talk about.
Is it something, do you think that they might have been incorrect? Is it something that they can do now? I mean, if we were to mandate sterilization of flexible endoscopes today, is that something that people could actually do? Or do they really have a valid point that we need to have a transition period here? It's not a step function. We have to kind of gradually work into this. And of course, patient safety has to be first. Can we have our cake and eat it too? Can we move from disinfection to sterilization while all along and during the whole time of the process still maintain patient safety? Is that possible?
Well, I think you and I both know that there's lots of outbreaks associated with these things, and it's very much underappreciated as far as the reports that we do see. That being said, if we have a known risk to a patient and one that we can absolutely not only correct, but actually eliminate, we can actually eliminate reprocessing in some instances totally. my sort of thought from an infection prevention standpoint is if I have the ability to eliminate risk, from a risk management standpoint, I'm going to do that. I'm going to take every step necessary to actually get rid of that risk. I mean, we saw this with needle devices, right? Where we had the safe needle technology. So as soon as I administered that dose, it clipped on and it actually already retracted. And therefore there was no more risk to the healthcare provider. Is that the same for every single flexible endoscope right now? No. But there are several FDA cleared endoscopes that are disposable in nature that do eliminate reprocessing. So if those are available, especially for high-risk procedures like ERCP, then I would be asking the question, why have we not moved to that? Is because they are available.
And this can go to an issue of trust we've been talking a lot about. Can you talk a little bit about the process of writing the guideline that maybe the audience isn't completely aware of? Who specifically was objecting to it? And the element of trust that who is primarily writing that AAMI document? Is this industry? Are these patient advocates, clinicians? Who are these people?
Well, I mean, if you look at the roster, it's a hodgepodge of all of those. You know, there's representation from different groups. And normally speaking, I think that's good to have representation from different angles. I will say the outside perspective, right? And I hear this routinely from sort of critics of the guideline is, you know, for example, the people that led the development actually work for industry. And that's a perception that has to be addressed. We've seen this sort of on the flip side with CDC, where they take a very polar opposite approach where they don't want any industry conflict. We do know that industry does bring clinical innovation to the market, but there needs to be a fair balance with that. And I think that is something that is a perception that has to be addressed by AAMI as well as others. You know, who truly is in charge of this? And sort of, you know, public review comments, all of that kind of stuff can help with this. But I would say that it's a very big issue when you have a guideline that's published and all of the clinical societies in that arena are rejecting it. I think that needs to cause a very immediate conversation at a high level to say, what went wrong here? How do we address this? And how do we make sure that all of us, right, including every single industry group, industry professional, as well as the clinicians and societies, are acting with the single best interest of the patient and also the healthcare worker. We can't just talk about patients anymore. It's also about our safety as well.
Has this happened before? Are you aware of a guideline like this being written by many different contributors and people from industry and clinicians and a group not endorsing it?
I've seen it happen probably one or two other times that I can recall. It's not something that I see commonly happen, no. But I also don't normally see guidelines that are spearheaded by people that work full-time for industry. So I think that is a very relevant criticism that can be made out there. So, again, if you look at other professional societies, they don't allow people from industry to write guidelines. So that can be a legitimate criticism that people might bring up.
And what about the issue of a potential financial conflict of interest? I saw that in the position statement that the GI groups wrote, they talked about that a little bit. Can you kind of fill us in on what that debate is briefly?
I couldn't speak to the underlying politics of that, but, I think there are inherent conflicts of interest that exist everywhere, right? And we all have some type of conflict. It's how we resolve it. And that's true for those that wrote the industry response, right? Many of them are, paid consultants and contributors to industry, just like you have folks on the AAMI committee that are full-time industry employees. Doesn't mean that they're bad. Doesn't mean that they're not evidence-based by any means, but how you resolve that and keep everything out in the open, I think, is what's critical here. But I, again, go back to, if I have a guideline from an industry society like that is immediately rejected by all the clinical parties that are in that space, you have to do a postmortem and figure out what went wrong here. Was that something that AAMI anticipated? Was it something they did not? I don't know, but it certainly is problematic because now we've, seen a large process and guideline creation and certainly an expense that has been rejected by the very individuals that were the target audience of it.
Well, I'm going to try to take this back a little bit towards that, coaching model that we talked about, because I think the trust piece is really inherent in all of that. And I think the level of trust that we're talking about is really industry wide, right? This conversation we just had is super important and very relevant to the challenges that are going on today. And even just in society and culture, I just feel like so many things are much more divisive, right? And that has an impact on how people feel secure. They might, whether they feel secure as a practitioner in general in their competency, whether they feel secure in the organization and the direction and the leadership, in all these different ways. And not feeling secure and trying to exist in, any kind of ambiguity, Hudson, I think, is where some of the burnout comes from. It can lead to that kind of internal conflict, right? And so I think a lot of your work in terms of coaching and resiliency is to help with that, right? Because it seems to me that the challenges to that level of confidence and sort of understanding and everybody being on the same page have never been greater than they are today in this day and time.
Yeah, the consequence of not having a resilient culture that is led well is tremendous right now. Losing one single clinician can have a groundswell effect. We can't even staff fast food right now, as you mentioned earlier in the episode, and yet we are expecting to staff highly specialized areas of healthcare. One thing that I would add to your point is that clinicians want to have trust in their institutions and their leadership that if something goes wrong, let's say that I contract COVID occupationally. Maybe it was also during the time of when we didn't have the proper PPE. Is my organization going to stand with me and do what's right? Are they going to help me take care of my family? Are they going to pay me my salary when I'm away? And that's something that is routinely brought up. That was even something that somebody mentioned to me this past weekend at a conference. And she said, we have a policy that says don't come to work sick. But she said, I know that I can't trust my employer to honor that when I am legitimately sick. So she said, we're forced to come to work ill, and then we're taking care of patients in the OR. And that happens also often. And so if there's no trust between the employer and the employee, that has to first be rebuilt before anything else is even possible. And certainly before we can build a culture of safety, which has got to be our end goal.
Yeah, it's so interesting because as an industry, we may not have, that aligned culture, but that we don't want to point to that and say that's the reason. And then that becomes an excuse. And instead, I think what you're challenging people to think about is not only leadership, but even as maybe people that aren't in positions technically of leadership, but even as coworkers have to, start at home, so to speak. And I think what you're talking about is very foundational. Like, how do you treat me as an employee? Not even like guidance in my career path or whatever, but just how am I treated and am I going to be taken care of? And do you value me as an employee is like the starting point. And I think sometimes managers and leaders get into this conundrum where all of a sudden the frontline staff is like, hey, I saw this new industry standard or guideline, or this is the best practice. How come we're not doing that? Oh, we can't do that because these people say that we shouldn't, that it's not really doable. And then the next thing you know, you kind of have, especially when people who want to perform in the most ideal way in the department will definitely challenge status quo. They may not be leaders, but they're looking at, this is what I'm going by. This is what my profession says I should be looking at. And so I feel like managers get into a position where they find themselves in a very uncompromising place when they're trying to manage the industry, the organization, and maybe a direct report who's an employee. So I'm assuming, and maybe I'm wrong about this, but I would expect that a lot of your work around coaching on resiliency is targeted towards leadership so that they're navigating that. I don't want to say middle management because it's not just middle management, but so that they're navigating that in a way that continues to at least foster an environment of trust, and that, hey, we don't always have all the answers, and sometimes we're put in compromising positions, but they're leading from a position of strength and trying to continue to maintain trust and security of the workforce? Or how does that work? What are components of the resiliency practitioner coaching model?
Well, I'm going to make it more elementary than that. We already know we have a staffing crisis right at the front lines. We know we have an even bigger crisis in getting people into leadership, to your point, Justin, in healthcare. That being said, go and survey and ask healthcare leaders that you interact with, have you ever had formal training to be a more effective leader? Almost all of them will say no.
And you don't get it in nursing school either. I mean, it was promote to incompetence long before the workforce shortage.
Right. So if we also see this with faculty, right, in nursing programs and other programs. These may be highly educated people, and I may have the best possible clinical nurse on the entire floor, and I promote that person to a management position because they're the best nurse. That's the wrong answer. They need to be the best leader of people. Uh-huh. And right now, the frontline clinicians just want to know that somebody has their back. And if you don't have somebody that is able to deliver that level of support, even if they're sort of managing up, then we foundationally have failed as leaders. And never in my life did I think as an infectious disease professional that I'd be spending more time coaching people on how to deal with difficult situations than the actual bug that we were trying to target.
Wow.
But yet here we are, and that speaks to the very vulnerability of healthcare, right? It's almost like we've ripped the Band-Aid off. The scab is now exposed, and it's not a bleed, it's a hemorrhage. And we've got to not be afraid to jump right in, put that tourniquet on, and then surgically repair the wound from the inside. And that's going to take all of us. Every single person involved in healthcare is part of that solution.
Wow. That is, you put that in such great context by saying, never did I think as an infectious disease professional, I'd be talking more about culture than the actual nuts and bolts, right, of what we do.
And how to prevent infections,
right?
It's not just, think about this. And I tell infection preventionists all the time, I said, stop saying you're an infection preventionist. You are not an infection preventionist. You're a healthcare leader. You're a problem solver. You're a quality improvement expert. You're a patient safety advocate. You're a statistician. You're a executive presenter. I said, you have to be all of those things. And this is true with everything in healthcare. If you're in some type of leadership capacity, you have an obligation to stand up for what is right and what is just, because our patients have that expectation, right? They're expecting when they get admitted to the hospital that there is a department. Each individual really owns this. And I always laugh when Joint Commission surveyors say they go into a hospital and they say, who owns infection prevention? And the answer is unanimously the infection preventionist. And that's the wrong answer, right? Because that's what people think. Right. The infection preventionist is a facilitator of that process, a consultant to it. It's like if the nurse at the bedside is not washing their hands, then everything falls apart. Right. And we still have problems with hand hygiene. And we've been at this since the 1800s. So that tells us that it's behavior and it's culture, and that the pandemic, trust, resilience, all of this boils back down to culture, leadership, support, a culture of safety, right? Making sure that you just do right. And as my grandmother used to say, treat everybody else the way you want to be treated, and your life will be much easier. And I still live to this, by this to this day. I don't care if you're the CEO or, an environmental services worker, you are equally valuable. Everybody plays a role in delivering care to patients, but we have to move away from this concept of, let's measure everything and report on all this and have all these committees, and actually get back to a common sense approach to delivering safe and reliable care that also protects the workforce and makes them feel like they're a valued part of a team that is doing something incredible, which is what every healthcare professional wants to do.
Respect. That's amazing.
Absolutely.
Hudson, you did an amazing job in this interview, and it's quite inspiring. And, we got into the weeds and we looked at big picture, and then we came back to the fundamentals. And I just want to put it out there, is there anything else that you feel like really needs to be said before we wrap up this interview? This went very fast.
You've got to go back to meeting somebody where they are in the journey, whether that's with a device or with a culture or a resilience program. Many of us may say, yeah, we've got the employee assistance program, so we're good with resilience. Wrong answer, right? That is only one piece. That's almost like pulling the fire alarm when there's a massive inferno going down the sort of hallway. The resilience program and investing in that, especially right now, is a way to prevent burnout, a way to prevent us losing valuable staff members. We cannot afford to lose anybody that's well qualified. We just cannot. And so as executive leaders, that's a huge responsibility. And it's timely right now. Every CEO of every hospital right now, their first and foremost priority is, can I staff the organization today in order to deliver the care that I promised, make a profit, keep my doors open, meet my regulatory guidelines? So right now is the time to grab the C-suite and have that conversation about what do we need to do to build a more resilient workforce, and frankly also maintain continuity of care. This absolute malarkey of preventing visitors from coming into hospitals for almost 2 years or from visiting their loved ones in a nursing home is absolutely appalling to me. As a patient, as an advocate, my own family member had COVID and I couldn't go in to see them. It's just completely ridiculous. And yet we expect then the bedside clinicians to be the clinician, the minister, the family, hold up an iPad when they're about to intubate a patient. We need to think about that. We really need to sit back and say, what in the world were we thinking here? And did we make the best decisions that encourage the staff to feel supported, that encourage the family members to be involved in their care? And I think we can all agree that there's some opportunities for improvement there. And so resilience and hardwiring this into the process and our cultures will not only make us more strong, but they will also make us more prepared for whatever it is that comes, whether it's a natural disaster, a man-made disaster, or a pandemic. It doesn't matter. We'll be equally prepared and on level footing to respond to that, knowing that we can function well as a team, that our executive leaders have our back, and that our patients can count on us to continuously serve their healthcare needs, even during difficult times.
Fantastic interview. Thank you so much for joining us today.
My pleasure.
That was Dr. Hudson Garret, Adjunct Assistant Professor of Medicine, Division of Infectious Diseases, University of Louisville School of Medicine. And, we talked about this, or we had this conversation today in the context of resiliency. But honestly, the industry is in a bit of a turmoil and has been throughout the pandemic. And then we have all of these IP folks, Larry, that listen to this podcast that have been under really strenuous working conditions for quite some time now. And, with everything that's kind of been going on and the exodus from the workforce, I think Dr. Garret did such a great job of succinctly wrapping up at a really high level everything that, sort of is going on right now and what is really required. Everybody's got to dig deep and be leaders and be part of the solution. And at the same time, he brought us all the way back down to the bottom or root of the issue, which is fundamentally we have to just sustain a culture that makes everybody feel safe so that we can then build upon that and really continue to focus on the care delivery. And I think that really speaks volumes about where we're at today after all of our worlds got rocked by the pandemic and healthcare.
Yes, I think he presented really well kind of the elements of this resiliency program and kind of broke everything apart, and which was very important to then rebuild it and fix it. And he really got into the elements and the details of what is broken and what needs to be fixed. And I think he particularly focused on the issue of trust. And trust is something that in some ways maybe we're losing it instead of endorsing it and building upon it. And we talked a little bit about the issue of trust in writing guidelines, the issue of trust in management, being in the war zone with the frontline clinician and practitioners. And I didn't know that the interview would focus so much on trust, but it was such a point well taken. We need trust, and from trust, everything good will happen.
Yeah. All right. That's going to do it for this week's show. As a reminder, you can support Transmission Control by subscribing to our podcast on Apple, Amazon, or Google Podcasts. You can also find us on Stitcher, iHeartRadio, Spotify, or simply search for Transmission Control on your favorite podcast application. We also have bonus content, but to access that, you've got to download our smartphone app for iPhone and Android. And while you're there, we'd certainly appreciate a rating and a review because your feedback is important to us here at the show. On behalf of Larry and myself, thank you for listening to this week's episode of Transmission Control.